Good evening. I'm Marian Rivers, and it's my pleasure to welcome all of you who came to this evening with investigators. We have a great crew from both Teddy and Daisy studies today, and we'll introduce people as we go. But let me tell you just a few words about who I am and what my role on the studies is. I direct the clinical division of the Barbara Davis Center. So as a pediatric endocrinologist, I've been seeing kids with diabetes for the past 24 years. And I got in childhood diabetes by serving in a summer camp for diabetic kids just after graduating from medical school and before starting my internship. So that summer changed of course, my knowledge about diabetes, but also my perspective on chronic diseases. And then through some observations that we've made in epidemiology of diabetes and clinical arena, I came to the conclusion that the only way we are going to conquer childhood diabetes is through prevention. We cannot see more kids coming down with diabetes every year. And this is what Teddy and Daisy studies are all about. We are doing those very demanding studies, and you know how much time on your part you sacrifice to come to the clinics and fill all of the questionnaires and share the information from your family lives with us. We do this for one and one purpose only: to find the cause of diabetes that comes from the environment, and to develop either a vaccine or a special diet to prevent this childhood disease. So thank you very much for coming today. We look forward to your questions after the presentations, because those questions often give us new ideas, new directions for our work, for our studies, and we do not suffer from paucity of data. We have a lot of data. Families like yours provided us with a wealth of information. We sometimes need a spark, an observation to ask new questions and look in new directions. So thank you so much for coming. I'd like to introduce, through those group pictures, our wonderful staff. Daisy and Teddy work very closely together, to the point that I really don't know at any point of time how much each of the study is paying each person. Our administrators do know, but there is a huge overlap, and we help each other and we interact. So it's like one big family in terms of staff and investigators. Those pictures, some of those were taken at the Barbara Davis Center front entrance, some at events that we had for Teddy participants or Daisy participants in the past. And I would like to, if you've never been to those fun events, like in Butterfly Pavilion, we went once to Rapids game. When you get the information about the next event, please join us, because it's not only about science, but also about having fun together. We'll share with you some of the findings from the studies and talk about our future goals. And I just have 2 slides to show, this one and the next one, to give you a quick update where we are in terms of enrollment and follow-up in those 2 studies. So the design is very similar, because Daisy, in a sense, gave the research community an idea how to approach this problem, and then Teddy was built on the Daisy model, where we are finding kids as close to birth as possible who either have high-risk genes or somebody in their family has already type 1 diabetes. Daisy started from 2,500 such families, such kids. And over the past 20 years, we've seen almost 200 of those kids develop inflammation in the pancreas, islet autoimmunity, which is a red light, red flag in terms of possibility of developing diabetes, but it not always leads to diabetes. So only about half of those kids with autoantibodies have so far developed diabetes in DAISY. There will be probably a few more, but I think we are pretty much seeing most of the kids who will ever develop diabetes or autoantibodies in DAISY. So it's a close study, it's a mature study. We are now looking at issues around puberty in early adulthood, what are the risk factors for progression to diabetes at those ages. TEDdy started much later. TEDdy started in 2004, 10 years later than DAISY, but it's much bigger. As you know, it's an international studies. 4 countries, Finland, Sweden, Germany, and the US, and 6 different centers. Size more than 3 times as large as DAISY, and we were even more selective in enrolling kids in TEDdy. So they are the cream of the crop, if you will, the highest risk of the high risk that we can identify. And already 500 of TEDdy participants have developed inflammation in the pancreas, and 160 have developed diabetes. So through this international collaboration in TEDdy, we want to get the answers sooner, as soon as possible. This is why the study is big, this is why it's international, and I'm really happy to tell you, with all of the turmoil going on in Washington, this study is very well funded. So also the NIH and research is getting hit by sequestration and all of the government reduction issues. TEDdy has not suffered so far, and let's keep it this way. If you know your congressman or congresswoman or senator, write to them to keep their hands, their scissors out of NIH way and cut Azure issues, Azure spendings, if possible, in our budget, but not the NIH budget. Okay? So, 2 areas in those 2 studies have received a lot of attention, and rightfully so. One is diet. It's so important to parents and to us investigators. What do kids eat, starting from the first breastfeeding and then through all of the introductions of foreign foods in kids' diet? Does this make a difference? Is the answer to our question, what causes diabetes, in diets of young kids? And we have the pleasure of having Professor Jill Norris with us today, who's been with the DAISY and TEDdy from the very beginning, and she is really the champion, not only here at the University of Colorado, but internationally, true champion in the area of childhood nutrition as it relates to childhood diabetes. She's a champion in many other areas, like genetics, for example, but today, please use her presence and knowledge to get all of the answers that you want to hear concerning diet and inflammation. She knows about celiac disease and asthma and other things, but let's focus on diabetes today. So this slide shows how many papers TEDdy has already published, submitted to journals, or have in progress in different areas like genetics, immunology, infectious agents. Diet is a clear leader here. But close behind is the celiac disease area. Of course, we are looking for causes of diabetes, and we know more or less what causes celiac disease, but those 2 diseases go hand in hand. When I see a patient with diabetes at the Barbara Davis Center, I know that this person, this child or adult, has 1 in 10 chance of having also celiac disease. So this is why we included celiac disease in both DAISY and TEDdy, and we have the pleasure of having Dr. Edwin Liu, who is an associate professor in the Department of Pediatrics at the Children's Hospital just next door in gastroenterology and nutrition, and he will be able to tell you all you need to know about celiac disease and answer your questions in this area. So I know I overstayed my invitation to make the invitations. Let's welcome Dr. Norris to start the scientific presentations for today.
Thank you, Dr. Rivers. I appreciate the opportunity to explain some of the recent findings we've had in the area of the research into diet and type 1 diabetes. We are looking at all different ages as potential times in which dietary exposure could be important. As you know, we ask questions about what you ate when you were pregnant. We ask about the diet during your child's infancy. And we ask about childhood, of course. There are a number of different candidate dietary risk factors in diabetes, and I call them candidate because we're researching them. We really don't have a definitive answer, and I can say that right now. But I've chosen this list because I think it reflects some consistency in what we've been looking at in the various time periods of a child's life. Certain things that have piqued our interest are dietary exposures in utero, such as cod liver oil or vitamin D, and other aspects of the diet. Breastfeeding and other aspects of the infant diet when you introduce solid foods is also an area of interest, in vitamin D, cod liver oil, cow's milk, etc. There's some consistency, but then there's some unique exposures that are specific to a particular time period. And I just put this in to say that in some cases when they're listed up here, it doesn't mean they increase risk. In some cases, these factors may be associated with a lower risk in our analyses of type 1 diabetes or autoimmunity. And that's what those little arrows mean. So the cod liver oil and the vitamin D and even other exposures during pregnancy, including breastfeeding during infancy, has been associated with a lower risk. And some of these other factors have been associated with a higher risk. And I'm going to touch on a few of these, highlighting some of the results in DAISY. I want to orient you to this slide. I'm going to follow up right on that first middle column that focused on infant diet. Some of the interest has been in certainly aged introduction of cow's milk and breastfeeding, but some of our more recent findings have focused on aged introduction of solid foods. And so what's unique, this was recently published from DAISY, and I wanted to orient you to this table. So basically, the way we report our findings in epidemiology is all about risk of the disease relative to if you were not exposed. So for example, we have this, we call it a hazard ratio. You could also call it a relative risk. What's your risk relative to not being exposed? So if you were exposed, or if your child was exposed to solid foods prior to the 4-month birthday, there's an almost twofold increased risk of type 1 diabetes compared to if the child was exposed to solid foods for the first time in the 4 to 5 month period. And just to follow up, this hazard ratio is 3, and it's a threefold increased risk if your child was not exposed to any solid foods until after the 6-month birthday, compared to if the child was exposed in the 4 to 5 month birthday. And you might wonder, why are these categories chosen in our analyses? And they actually were purposefully meant to reflect the current recommendations by the American Academy of Pediatrics as to when it is time to consider introducing solid foods to the child. And that's usually between 4 and 6 months of age. They don't say definitively, but they say this is the time when you can start introducing. And in some cases, it may actually benefit the child nutritionally to start foods at that time. Another interesting finding that we found in DAISY is that if the child was still being breastfed when foods containing gluten, which is wheat, barley, rye, when foods were containing gluten were introduced into the infant diet, the breastfeeding actually had a protective effect. It decreased the risk of type 1 diabetes compared to if gluten was introduced into the infant diet when the child wasn't being breastfed. Okay? So this is a very interesting finding, and while we're not entirely sure what this means, this gives us directions to research and reasons why would the risk be decreased. Again, these are not absolute risks. These are relative to comparisons of not being exposed to a certain factor. Well, what do we mean by solid foods? And I thought you would be interested to see what some of our DAISY results show. You may or may not know this. If you're a mom, you probably do know this, that the most common first solid food introduced into the infant diet, probably in the United States, but certainly you'll see in DAISY, is rice. It's recommended. It has a low antigenicity, or in other words, you typically don't react against it that much. So it's recommended as a very first food. The reason why I point this out is that some of our descriptive data from the TEDdy study, the international study that Dr. Revers referred to, suggests that this is not the case in other countries. That the first solid food is not rice, but I'll get to that. But you'll see that sometimes foods are introduced into combination at a very similar time. But these are the types of foods we're looking at: vegetables, fruit, wheat and barley, which would be the gluten-containing foods, and then, of course, rice and oat. Well, I'm going to skip to the next topic, if that's okay. I had mentioned in the previous summary slide that omega-3 fatty acids is an area that we have been researching, we and others have been researching, both in pregnancy as well as in infancy and in the childhood diet. But why is that? Why were we even interested in this? And there was a study from Norway that showed that children with type 1 diabetes were less likely to have gotten cod liver oil supplements during infancy than children without diabetes. So this is a classic first step comparison. They looked at kids with diabetes and looked at kids without diabetes and tried to see what was different about their dietary exposures in the past. So this piqued our curiosity because cod liver oil is an excellent source of the fish oil omega-3 fatty acids that are probably well known to most of you, which are DHA and EPA. You'll notice that even in infant formulas are being fortified with these omega-3 fatty acids. So DAISY examined whether omega-3 fatty acids in the diet were associated with diabetes autoimmunity and progression to diabetes in the DAISY cohort. And Dr. Revers showed a slide similar to this, but I would like to reorient you. As you all know, DAISY, as well as TEDdy, is sort of predicated on this model that you start with a child who has a genetic susceptibility, which is not absolute, though. It's just a susceptibility. And along the way, something happens, and they develop an autoimmunity, an islet autoimmunity, or inflammation in the pancreas. And then along the way, they develop diabetes. But not everybody who has a genetic susceptibility goes on to autoimmunity. And actually, at least as far as we have followed kids so far, not everybody who develops autoimmunity goes on to diabetes. So it's a very interesting question. Now, this is showing hazard ratios or relative risks in a different format. This is a figure. And you'll see here, this hazard ratio here is 0.45, which is a little bit different than the other hazard ratios. And what this means is that children who were eating more omega-3 fatty acids in their diet had a lower risk of developing autoimmunity than children who had lower levels of omega-3 fatty acids. I apologize. So a relative risk under 1 represents a lower, a relationship that suggests an inverse association or a lower risk if you were exposed. So this was from, I'm sure you're familiar with the dietary surveys that you've all filled out for the DAISY study and the TEDdy studies. This is one of the reasons why we're asking these questions. We can get from that dietary survey what these kids were eating, how much omega-3 fatty acids. We can also ask how much vitamin E, etc. And from that survey, we were able to determine that reported intake of omega-3 fatty acids actually was associated with a reduced risk of autoimmunity. We actually had a biomarker of the same omega-3 fatty acid, just in case we might have been a little bit worried about self-reported dietary intake. And this is just a level of omega-3 fatty acids in the blood. And we see a similar association. Again, this is reduced. It's less than 1. So kids who had higher levels of omega-3 fatty acids actually had a lower risk of autoimmunity than kids who had lower levels of omega-3 fatty acids. We actually then asked the question whether what they were eating, omega-3 fatty acids, had anything to do with going on to diabetes. So in kids who already had autoimmunity, did you see that what they were eating in terms of omega-3 fatty acids was associated by with progression to diabetes? I apologize. And no, we actually didn't see that. So while omega-3 fatty acids was associated with a decreased risk of autoimmunity, we didn't see an even greater risk for diabetes in kids who had the autoimmunity in place. Now, vitamin D is an interesting story. There have been a lot of I saw smaller retrospective studies that have suggested that vitamin D might actually be protective or be associated with a lower risk of type 1 diabetes. These would be in studies in which they're looking at diabetes, not prospective cohort studies. And we thought we would look at that in DAISY. And once again, we used those dietary surveys and we were able to measure how much vitamin D was reported in the child's diet. And we found that dietary intake of vitamin D was not associated with the risk of autoimmunity nor diabetes in the DAISY kids. And what this meant was that the kids who developed autoimmunity were eating just as much vitamin D as those who didn't develop autoimmunity. And same for the progression of diabetes analyses. We didn't see any effect for development of autoimmunity or that next step to diabetes. And similar to the previous analysis, we also had a biomarker, so we could actually measure vitamin D levels in the blood. And again, in DAISY, we saw that the vitamin D levels were also not associated with risk of autoimmunity or diabetes. And that's just repeating what I had just said. Again, the levels were similar whether or not you developed diabetes or autoimmunity. I thought you'd be curious, however, but in the process of looking at this, and I know vitamin D has received a lot of attention not just for diabetes, but for other conditions, you might be curious to see what it looks like, vitamin D levels looks like in the DAISY population. So these are all the kids in DAISY. And down below, it's really hard to read, this is the 9 months up to 10 years. And this bar, this line here represents levels of 25-hydroxy vitamin D, which is essentially a measure of vitamin D status that clinicians typically use. And you'll see, what I find interesting is that it's relatively high or sufficient in the younger ages, but we do see a decline as kids get older. And we're not entirely sure why we see this decline. It could be that one of the sources of vitamin D in the diet is milk, and kids who get older are less likely to drink milk for a variety of reasons. Maybe that's one of it. They also may spend less time outside. And one of the things that you may not be aware is that one major source of vitamin D, particularly in sunny Colorado, is sunlight. So your body can make vitamin D if you're out in the sun. But as kids go to school and as they may spend more time in front of a screen, they may actually be making less vitamin D in their body. Again, this doesn't necessarily impact risk for autoimmunity or diabetes, but I thought it would be an interesting trend to show you and to see what type of powerful information we see in the DAISY study. Now, I wanted to address this because, as Marian said, or Dr. Revers said, the diet is a very tangible thing to parents. And people want to know because it's something you have to make a decision about every single day. So I fed my son cereal when he was 3 months old. Should I be worried? My daughter has type 1 diabetes. Is it because I didn't feed her enough fish? These are very real questions. But we can't address these questions in the way we're doing the epidemiologic study that we're doing. What we measure and report in our studies are meant to describe risks in a population, and they really cannot be translated to the individual to predict if someone is going to get diabetes or explain why they got diabetes. We're not quite at that level yet. We haven't done that type of analysis because we don't have the right materials. There are a number of risk factors and protective factors, as you saw from my previous presentation, that we are investigating for risk of diabetes. And what we don't know is whether they have to work in combination, whether there's a timing issue. This is the reason why we are following the wonderful Teddy and Daisy kids to get this information, and that at some point we might be able to predict. The bottom line is we all know that parents do the very best they can with the information available to them. And one of the purposes of these studies is to provide information so parents can make decisions. I just wanted to briefly orient you with Teddy. Teddy doesn't have any papers looking at the outcome of autoimmunity or diabetes and diet just yet. But we have a lot of interesting comparisons, in part because it's an international study. And it's been a great learning experience for me, doing most of my research in the United States, and then being exposed to the research in other countries and really being aware of being very careful about how you interpret variables, such as the solid foods variable, but I'll get to that. Oops. It's not advancing. I'll try an arrow. Okay. This is a graph that shows duration of breastfeeding in all the different countries participating in Teddy. It's really hard to see. Each line represents a site. So the black line, which I'll point out better, is actually Colorado. And then we have Finland in the yellow, Georgia in the red, Germany in the blue, Sweden in the green, and Washington State in lavender. I'm just put a line here for 12 months just to orient you. So just to give you an idea of how many people are still breastfeeding at 12 months in the Teddy population. So down here in green, you see Sweden, about 15% of the population is still breastfeeding at 12 months of age. Washington is up here at about 40% of the population still breastfeeding at 12 months of age. And Colorado is here at about 28%. And you see that there's of course a wide range all along here. But this is, again, total breastfeeding. Or any breastfeeding, however you want to define it. This is exclusive breastfeeding. So this is basically the state in which the child has only received breast milk, hasn't received any solid foods or any formulas or anything else. And you'll see it's a very different picture. What you see here actually is, let me use this. This immediate drop here is just probably likely the people who start supplementing their breast milk with formula right away, say in the hospital or very soon after. And then you see a very different decisions in terms of length of exclusive breastfeeding. And this is 6 months here, to give you an idea that it is a shortened time scale. Why? Because it's difficult to exclusively breastfeed for a long time. And in fact, given that the Academy of Pediatrics is recommending the start of solid foods at about 6 months, this kind of dovetails very nicely with what is recommended. Now this gets a little bit at some of the country different. Yes, go ahead.
Not recommended in Germany because they didn't have the giant drop.
No, you are very astute. This blue line here is Germany, and Germany sometimes stands out a little bit in our Teddy sites, and it's got probably a very real explanation. I'm not entirely sure that this represents Germany as a whole, but it just so happens in Teddy, the German site actually has a very high proportion of first-degree relatives with type 1 diabetes. So a higher proportion of their kids in their study are actually first-degree relatives of someone with diabetes. And so what we think might be happening is because diabetes is in the family, there may be some efforts on the part of the family to breastfeed longer or exclusively breastfeed longer, simply because they choose to based on the risks that exist in their family. But we haven't necessarily explored that. But
So are the Germans then recommended the same solid food time frame that we are?
yeah, and they're presented in different ways, but it's around the same time frame. Yes, it does not mean that everybody follows the recommendations because that's what they are. And again, it's choices that parents make based on the information that they have and other things going on in their family. Okay. I don't want to run over too much. I just wanted to show you some more things. This is what I was getting at. So, okay, well, when you end exclusive breastfeeding, how do you do it? Well, in the U.S., you typically do it with formula, which makes sense. You start supplementing with formula. But then sometimes, rice is a very first early food, but so is fruit there. This is, again, the Teddy population, a little bit different maybe than the Daisy population because Teddy has 3 sites, one in Washington, Georgia, and Colorado. In Europe, you still see that high first non-human substance being formula, but you don't see rice, and you see fruit and root vegetables as being the first solid food being introduced in the diet. So potatoes and carrots seem to be a popular first food in Europe. Rice is a popular first food in the United States. So when you just use the term solid foods, you may be talking about very different things in Europe than you are in the United States. This is the type of thing that you have to be careful about. Again, this just shows you a little bit about what types of formulas people use. It differs by country. Mostly, you see cow's milk formulas in this gray bars, most in Sweden. What's different here is a large proportion of individuals in Finland choose to use a fully hydrolyzed formula, like Nutramigen, I guess would be what would be on the market in this country. And then in Germany, they choose to use a partially hydrolyzed formula, which I'm trying to think of a good name, maybe Good Start, something like that, which is in other words, it's not quite as broken down. It's just interesting, again, so if you're just looking at when formulas start, these kids may be exposed to very different things when they first are exposed to a formula. It could be cow's milk based or soy, or it could be a partially hydrolyzed formula. And hydrolyzed just means the proteins are broken down. It's thought to be easier to handle for certain infants. Here's solid foods. Okay. I spoke a little bit about gluten, so I thought I would show you some of the different behaviors in introduction of gluten in Teddy. But I don't want to skip over this either. There. I just thought I would show that Germany, again, may be related to that different makeup of families, is delaying the introduction, or they're introducing gluten later in the infant diet than, for example, Sweden, which actually tends to introduce it relatively early, still within that window. I mean, it's a very steep curve. You can see that parents are listening to the recommendations and making decisions, but there's some variation and some differences by country. I didn't really talk about the science behind looking at maternal supplements, but this would get at exposure to vitamin D and perhaps omega-3s during fatty acids during pregnancy. So I thought I'd show you some trends of maternal supplement use during pregnancy. This is in the Teddy moms. And what you see here is that vitamin D is actually used a lot in the United States, usually through a prenatal vitamin, basically your standard PrEP. But you see it's not very much well used in Germany or in Sweden, which is interesting. You see there's a trend to start using fatty acids, omega-3 fatty acids. But this is a trend that's happened over time. This is 2004, this is 2010. And you see that same trend in Germany, a little bit in Sweden and in Finland. And then I thought I'd point out that there's just a bump, a little bit. People are beginning to use probiotic supplements in pregnancy. Not very common, but it's one of those things that we need to be aware of when we're doing these types of research because it's over time, and we have to understand the sort of temporal trends as well as country differences. And again, this is dietary supplement use in the kids. So what kinds of supplements are the Teddy parents giving their kids? And vitamin D, Finland, Germany, Sweden are across the board almost 100%. U.S. is down to 29%, which is interesting because vitamin D wasn't that used in pregnancy, but it's used more in the first year of life in kids. Probiotics has a very interesting country difference. In Finland, there's a very high use of probiotics in the first year of life, and not so much in the United States here. And then use of omega-3 fatty acids, and this could be in the form of cod liver oil or it could be in the form of other types of preparations. Not very common in the first year of life, but there, and it's possible that it may increase. Again, these are just behaviors. We're not telling parents to do a particular thing. This is just understanding what our populations are doing so we can measure the risk appropriately. That's all I really have. I thought I'd leave some time for questions, and I think there's also going to be a panel, too, that you can save them. But go ahead.
So you said that the only thing, and I didn't hear anything about probiotics earlier in your discussion as to its effect on this. But vitamin D, which everybody's doing, has no effect. Omega, which nobody's doing, is the only one that's showing an effect of lessening the risk of developing autoimmune, however that works. Is there, would that number of that what was it, 45 and 65%, would that be different if those numbers were higher, the 12, 11, 4, and 1?
Do you want me to go back? This one?
Sorry, yeah, 8, 1, 10, and 4. I got those all over.
Well, this is a slightly different analysis than what I presented before. What I presented before was sort of measuring the entire diet and how much omega-3 fatty acids was in the diet that the child was eating. We did account for supplements in that analysis, but you're right, similar to this, very few of the kids in DAISY were taking omega-3 fatty acid supplements. So most of the variation in omega-3 fatty acids in those analyses was from dietary intake, not supplements. But I don't know if I answered your question.
So the question is, basically, if these numbers were up where the probiotics or the vitamin D numbers were, would we see a much, much smaller development of autoimmunity? That's a question that we would really like to answer. One of the things that DAISY hasn't looked at, in part because we didn't have the right data, is what is the impact of supplementation of omega-3 fatty acids in the first year of life, like true supplements. But it is something that we don't know. We really don't know.
Let me share one more piece of information with you. There was a clinical trial, pilot trial within what is called the TrialNet project, trying to supplement the omega-3 acids both during the last couple of months of pregnancy and after birth, then directly given the child. It was a pilot study, so not big enough to really have enough power to say if it worked or not. But there was no difference. Even though we had great hopes that it would show protective effect of omega-3 fatty acids, the study called NIP did not show any great promise, and it has not developed in a vigorous clinical trial. So we've been in this field for a long time, and it often happens that the first study, especially with a special population and small, may be negative. I don't think this is the end of the story. We are very interested in this potential supplement. It may not prevent all of the pieces of diabetes, but in some families, in some kids, it may be helpful. We are not advertising to them of the families uses this particular supplement, but it's in all fairness, we have to share this information with you.
We'll leave that on.
And there's a question back there. Yeah.
I read a study relating sodium intake to autoimmunity. I'm wondering if there are any
Very interesting question. That was actually brought up at the last Teddy Steering Committee meeting because the paper had recently come out. But we're not sure we can adequately look at it with the data that we've collected, because sodium is actually something that's quite difficult to measure in the diet accurately. But it is certainly something that we can design perhaps a sub-study to look at it more carefully with a different instrument. We did consider it because we thought it was an intriguing finding, but we weren't confident that our instrument, our diet instrument, was going to pick up sodium well enough to look at it. But it's still on our list to see if we can find another way to measure it in the kids to see.
Did you have any data between the correlation of those kids that actually have been diagnosed with celiac disease? How many of them, or what is the percentage of them that will have childhood diabetes?
That's a very good question, and actually Ed might be able to answer that better than I. Would you?
Turn that mic on the bottom.
Okay. So I think from the data that we have right now, it depends on whether or not you have diabetes first or celiac disease first, and I think this is probably just related to the gene combinations that you have. But right now, the quoted numbers and numbers that we've consistently seen is that if you already have type 1 diabetes, the risk of getting celiac disease is about 8 to 10%. Now, if you've got celiac disease first, the risk of getting diabetes just seems to be lower, and it's not something we really understand very well right now, but we think it might be related just to the gene combinations you have. So the genes that put you at risk for diabetes are very permissive for also developing celiac disease. But the gene combinations that are the gene combinations that put you at a higher risk for celiac disease, where you may develop that first, don't seem to be as permissive for developing diabetes. There's some thought about whether or not a gluten-free diet may, reduce the incidence of diabetes, but right now there just isn't enough data to support that.
Are there other questions?
Well, there will be an opportunity after Dr. Liu's talk to ask some more questions. Thank you.
Okay, so, I've been seeing a lot of the kids from Teddy and also from Daisy for evaluation of celiac disease. And I think one of the things that's been relatively consistent is that a lot of families are sort of surprised that, when they hear about celiac disease, because it really wasn't on the radar to begin with. So I just want to back up a little bit and just give you some information about celiac disease and give you an overview of what kind of things we've learned. So, celiac disease is no longer considered rare. In the past, we used to think of the frequency as being about 1 in 5,000 kids, but that turns out to be just the tip of the iceberg. And so this, the celiac iceberg is always present in some kind of talk. But it turns out that most of the kids, or even adults who have celiac disease, are probably asymptomatic initially, or maybe at least unrecognized. And so the prevalence of celiac disease in the general population isn't really 1 in 5,000. It's probably closer to 1 in 100. And we're just going to go past that. So it's common. It affects about 1% of the general population. And celiac disease is an autoimmune condition, right, that affects the intestines, and it's as a response to the gluten that's seen in the diet. So people who have celiac disease are treated by lifelong avoidance of gluten, which is basically the gluten-free diet. And that includes wheat, rye, and barley. And so the genes that play a role in celiac disease are similar to the ones in type 1 diabetes. And so the ones that we look at are the HLAs, we call it DR3, DQ2, and the more minor one, DR4, DQ8. And these genes, one or the other is essential for celiac disease to develop. If you don't have those genes, your chances of developing celiac disease are very, very low, almost negligible. The thing is, these genes are present, they're common. They're present in about 40% of the population. And if you do have celiac disease, though, 92% of those people with celiac disease will have a DQ2 gene, and 8% will have a DQ8 gene. So because these genes are so common, though, that means only a subset of kids with these genes are going to develop celiac disease. So just having these genes, just like in diabetes, having the genes doesn't mean that you're going to develop an autoimmune condition. And like I said, because these genes are shared between other autoimmune diseases, celiac disease can be seen in association with type 1 diabetes and also autoimmune thyroid conditions. So the clinical presentation for celiac disease can vary, though. Classically, we would see kids who had an overt presentation. It wasn't subtle. These kids would have abdominal pain, diarrhea, they'd be bloated, or they could get constipation, they'd be really irritable, they'd have growth failure. So these kids would be really sick. But we also know that there's adults who end up getting diagnosed with celiac disease who've probably had it for a very long time. But it was just, it was very subtle, where they may present with iron deficiency anemia, or you may present with osteoporosis, and there's actually an increased risk of developing intestinal lymphoma with untreated celiac disease. And then probably the biggest category that we're seeing now, because they're screening kids, are those who are asymptomatic, and perhaps the more proper term is sort of unrecognized. So kids that we're picking up through screening, and they may have a little bit of belly pain here and there, but you certainly wouldn't have brought your child into the doctor for those symptoms. So, celiac disease used to be considered just, an intestinal condition. But at this point, it's really no longer isolated to the GI tract as we get to know this condition more. So we used to think of celiac disease as, a condition where you have, intestinal disease resulting in something called villus atrophy in the intestines and malnutrition. And this was really the old paradigm. But nowadays, we know that it's more than just a gut problem. And it can affect you in many ways. It can affect your brain, your central nervous system, and lead to problems with balance called ataxia. It can lead to seizures. It can be associated with depression. And now, certainly not all these conditions mean you have celiac disease, but since celiac disease is very common, there's been a lot of these symptoms that have been reported in association with it. It can be associated with heart disease. In females, it can lead to miscarriages and infertility. It can lead to delayed puberty. For the bones, you can have thin bones, and you can have osteoporosis. You can get fractures easily if your bones aren't very well mineralized. It can lead to arthritis, and kids can also have dental anomalies. We call it like dental enamel hypoplasia, where the teeth just aren't very well developed. It can lead to anemia and fatigue. It can lead to hepatitis or irritation of your liver. It can give you certain kind of rashes or give you a lot of ulcers in your mouth, and you can lose your hair. So it can affect you in many ways outside of your intestines. So who requires screening for celiac disease? Well, certainly if someone's sick and they've got a lot of symptoms, a doctor would go ahead and screen them for celiac disease. But like I said, many kids don't have these kinds of symptoms, and so what we do is we look at the groups who are actually at risk for celiac disease, and those really include the individuals who have type 1 diabetes, people with autoimmune thyroid disease, individuals who have Down syndrome or Turner syndrome and Williams syndrome, people with a specific kind of immune deficiency called selective IgA deficiency are at higher risk for celiac disease, and certainly first-degree relatives. So if you've got a family member with celiac disease, the recommendations right now are that you should probably get screened for celiac disease as well. Now, with all these groups that are at risk, though, the common feature is that you have these genes that predispose you. You have one of these HLA, DQ2 or DQ8. And, without those genes, like I said, your risk of getting celiac disease is almost zero. So how do we screen for this? Well, we screen by measuring a specific antibody called the tissue transglutaminase antibody. It's the TTG test. And, in these studies that we're doing with Daisy and Teddy, or especially if someone who's asymptomatic, a single positive test sometimes may be enough, but oftentimes we want to repeat it because we want to be sure before we act on this that these antibodies are they're really around, that they're real. And so if you have a persistently positive test, it doesn't mean that you have celiac disease necessarily, though. If your antibodies are positive, rarely it can mean that these antibodies, they could be transient. Rarely we've seen these antibodies appear and then just go away on their own. But more commonly, it may mean that, the autoimmune process has started, and this may eventually lead to celiac disease. Or it can mean that, yeah, you've already got celiac disease. And the way we diagnose celiac disease is by doing endoscopy. And this is by, we do endoscopy and we biopsy the small intestine. So we take a scope, camera, and go down the same path that food goes down, and go into your stomach. We exit the stomach and go into your small intestine. It's called, the first part of your small intestine is called the duodenum. And, we take biopsies from there and we look at this under the microscope. So if you look here, a normal duodenum would be, over here, and this is what a healthy duodenum looks like. And then if you've got celiac disease, sometimes if it's really obvious, you may see some cobblestoning where you start seeing some thinning of the lining of the intestines, or scalloping where you see these little grooves here. So these are some features that you can see visibly that would suggest injury in the intestines. But the diagnosis really rests on the histology. So we look at this under the microscope, and what we're looking for is the villus atrophy. So your intestines aren't perfectly smooth. Your intestines have a lot of finger-like projections that basically increase the surface area so that you can absorb your nutrition better. Okay, so this is what a healthy intestine looks like. It's got these long, nice-looking finger-like projections to help you absorb your nutrition. And when you've got celiac disease, it's almost like a lawnmower just went and cut these off. And so you get villus atrophy. They become really, really flat. And these pits here also become deeper. And when you look at under a high-powered microscope, you'll see what we call IELs, or intraepithelial lymphocytes here. So this suggests that there's inflammation going on. These cells are going and they're invading your intestines and causing injury to your intestines. So that's how we would diagnose celiac disease. The antibodies would suggest it, and we do a biopsy and we confirm it this way. And an endoscopy would take about 8 minutes. If anyone ever needed endoscopy, you pretty much spend half a day with us. Okay, but to meet with the nurses and the anesthesiologist, and you fall asleep. The procedure itself takes about 8 minutes, but then you get some time to wake up and you feel okay, then you go home. So it's a day procedure. So if you get diagnosed with celiac disease, how do we treat it? Well, it's basically a gluten-free diet, and it's lifelong and it's strict. So we're very careful about cross-contamination, meaning, you don't even use the same toaster. You don't share the same toaster as someone, who's using gluten in their, a toaster that's been exposed to gluten. You don't want to use those. You want a dedicated toaster to toast gluten-free bread, for example. Or if you're having a steak, you have to think about the meat and what it's marinated in, because some sauces could contain little bits of gluten in it. So that's how strict we want to be when we're doing a gluten-free diet for someone with celiac disease. So it's certainly not trivial. In education with a dietitian is going to be very important to learn about these tricks and learn about where you might be missing cross-contamination. Support groups are very important because sometimes kids feel very alone with this diagnosis, and families can feel very alone with this diagnosis. And so I think supporting them is very important. And then we follow up with the kids, frequently to monitor for complications. We look at those antibodies and make sure that those antibodies can go away, because we do expect the antibodies and the intestines to completely heal on a gluten-free diet. So what have we learned about celiac disease from Daisy and Teddy? Well, I'm just going to give you an update for where we are with Teddy. Okay, so this data is from July 31st. Okay, and so we followed these kids on, a mean time of about 5 years. Okay, and for the kids that have been eligible, who have got the right HLAs for celiac disease, we've screened, 6,403 of these kids. And we've got 1,000 kids who've already had a single positive test for the TPG antibody, so who may have some evidence of celiac disease autoimmunity already. And out of these 1,000 kids, 786 of them have had antibodies more than once that are still positive. So they're persistently positive. We call this celiac disease autoimmunity. And now the question is whether or not these kids actually have celiac disease, or what's going to happen to them. Are these antibodies going to go away, or, are they going to have intestinal injury or not? And so total in Teddy right now, we've biopsied 350 of these kids, and 291 have a diagnosis of celiac disease at this point. And we've also got some additional kids who've got really high levels of the antibodies, who we haven't done the biopsies yet, who may end up having celiac disease. So some things that we've learned is that we're getting the idea of what the natural history of these antibodies are. Remember, I told you that these antibodies rarely, but they can go away when they're positive. Usually they're going to be lower levels of the antibodies, and typically so what we've seen is, for example, in a child we can see this from birth when, this is from Daisy, by the way, the antibodies would be negative from birth, and they continue to be negative, but at some point during their follow-up, the antibodies might become positive. And if they're persistent, we would do a biopsy, and, in this situation, the biopsy showed villus atrophy or injury to the intestines, and this child got diagnosed with celiac disease. They went on a gluten-free diet, and you can see that the antibodies started to go away. And for a different reason, this child had another biopsy, and turns out that the intestines had completely healed. So we can look at the natural history for some of these kids now, and we can see we can see that these antibodies have been negative from birth, and suddenly we know exactly when they turned positive. We diagnose them with celiac disease, and on the gluten-free diet, you can see that these antibodies start to go away, and that's what we expect. We expect the antibodies to go away on a gluten-free diet if you're diagnosed with celiac disease, and we expect the intestinal biopsies to completely normalize. But we don't normally repeat the biopsies. So this gives us a nice natural history for what this whole process is. We've also learned through these studies that typically the higher the antibody levels, the more likely you're going to see injury to the intestines. And so this is really important because this helps us decide when to do the biopsies. And we don't want to rush and do a biopsy right away if your child's antibody positive, because it might be very early in the process. And if we do a biopsy right away, the intestines might look normal, but if we repeated it, if we did another biopsy 12 months later, we might catch it then. And so we're trying to find the optimal time to do these biopsies. And so this, we've learned that, with the increasing amounts of villus atrophy, the antibodies tend to be higher. We've also learned that these HLAs, these gene risks, aren't equal. So your risk of developing celiac disease really depends on which gene combinations you have, one that you inherit from mom, one that you inherit from dad. And this is Teddy data now, looking over the first 60 months, the first 5 years of life, we can see that, wow, this is the percent. So 29% by 5 years of age of kids who have a DQ2 inherited from both parents are at risk of developing celiac disease antibodies. Whereas if you've got a single DQ2 gene, your risk is about 13%. And if you've got that lower risk gene of DQ8, your risk is about 9%. So now we're able to start to stratify the risk of developing celiac disease just by looking at your gene combinations. And so we hope that, we'd be able to someday try to, in any kind of interventions or counseling that we do, we might be able to personalize the recommendations based on your genetic profile. And through DAISY, we can start to estimate the incidence of celiac disease in the general population because the immense amount of data we have, we're able to kind of give you these kinds of curves. And so this is estimating the incidence of celiac disease in the population in Denver. And by 5 years of age, we're estimating that about 1.5% of the population, based on this data, probably has antibodies for celiac disease. Okay, and by 7 years of age, the estimates now might be around 2.5%. And by 10 years of age, the risk of getting antibodies might be about 3%. And this is awfully high because the quoted risks right now we have are about 1% in the general population, right? But we're looking at this in kids these days, by 10 years of age, probably about 3% of them have these antibodies that put them at risk for celiac disease. So this is incredibly high. And, this number is really notable because in Sweden, there was actually an epidemic of celiac disease back in the 80s and 90s. And it turns out that they figured that the reason why there was an epidemic of celiac disease was probably related to a combination of factors involving breastfeeding and the timing at which they introduced gluten in their diet. But when they looked at the kids 12 years later who were born during an epidemic, the prevalence of celiac disease in those kids born during that era was also 3%. So this is sort of provoking, but it's
provocative, but you kind of wonder if we might be in the middle of an epidemic right now for celiac disease based on these numbers. And so there's still a lot more to be learned about this, but this is sort of the information that we're gathering from Daisy and from Teddy. So other findings that we have so far is that, well, when we compare the countries, so Dr. Norris already showed you that, the countries are doing different things in terms of their feedings and their supplementation, right? Well, one thing that we're finding is the risk of developing early celiac disease is much higher in Sweden compared to the other countries. In fact, when you adjust for all these factors, the risk of developing celiac disease in Sweden is almost twice as high as the risk of developing celiac disease in the US. We also know that females are at a higher risk of getting celiac disease, maybe about 1.5-fold higher than males. And also having a family history of celiac disease increases your risk. And that's not surprising because the HLA genes that we screened for in Teddy and Daisy aren't the whole story. There's certainly dozens of other genes that put you at risk for, that increase your risk small, but they do increase your risk for diabetes and celiac disease that remain to be studied. So what do we hope to learn from all this, as we move forward? Well, for these studies, right now the next step is we want to try to identify the triggers that lead to celiac disease. And we're going to be following a lot of the models that are being done for figuring out the triggers for diabetes. And this is going to include looking at the dietary factors that might put you at risk for celiac disease, looking at infectious events, gestational factors, and certainly other genes. Thank you. Any questions?
So I suggest that we all sit in the front row and entertain all of the questions that you guys might have at this point. Of course, I would like to thank both of the speakers. It was very interesting even to me, although we interact a lot.
There's a glare up there.
Is there any benefit to a diet with a low glycemic load?
Are you referring to diabetes or celiac disease?
Oh, I'm sorry, diabetes. That was diabetes.
Well, Daisy has actually looked at that question. Again, from the food frequency questionnaires that we collected from the kids, we can calculate glycemic load or index of the diet. And what Daisy found was that glycemic load or index was not associated with the development of autoimmunity in our kids. However, it was associated with the progression to type 1 diabetes. So in kids who were already had autoantibodies, kids with a higher glycemic index progressed more quickly to diabetes than kids with a lower glycemic index in their reported diet. We don't really know how this works, actually. It could very well be stress on the pancreas to some extent. It could be a little bit of what we might call unmasking. So kids with a very high sugar diet or something might have higher glucose levels in general, and therefore, since we're screening them so frequently in Daisy, we might pick up a small rise in that and check them out more carefully. But that is what Daisy has found, and we're trying to follow up on that to see if there are particular sugars that might be involved, and not just the glycemic index, but we really haven't been able to pinpoint it beyond that sort of general measure. And so we're not entirely sure what it's telling us.
It's a great explanation. Just from clinical point of view, what we see often in kids who have the autoantibodies but are not diabetic yet, that those who are very active, are lean, and also eat maybe less high glycemic index foods, they tend to go longer without diabetes. There has been no clinical trials; those are just anecdotal clinical observations. But I think, if you're in the situation that your child has antibodies, you may consider really signing him up for basketball and football and soccer and anything that makes him move.
Okay, next question. Trisha, you want to, is there something here? Next one.
So it used to be called juvenile diabetes. How long, what kind of a span is that? My dad was diagnosed in his 30s with type 1. They still called it juvenile. What is that?
50s now it's old 30s, how does it go? So it's all relative. The best example to this shift in what's juvenile, what's adult is that we even changed the name of our center from Barbara Davis Center for Childhood Diabetes simply to Barbara Davis Center for Diabetes. We got a lot of complaints from our patients. We have a large adult clinic with more than 2,000 patients who were diagnosed as kids or young adults, but now are in their 40s, 50s. So it's not just a center for childhood diabetes. It's a center for type 1 diabetes. And it's all the same. It's all the same. There is a misconception that most of the type 1 diabetes is diagnosed among kids. Less than half of all of the cases are diagnosed below the age of 20. So we see a lot of people in their 20s, 30s, even 70s coming down with type 1 diabetes.
For Dr. Liu, the biopsies you showed for the child, 6-year-olds, showing that it was a normal biopsy after going on a gluten-free diet, is that standard for celiac when they go on when they lose all the gluten, that everything goes back to normal, their intestines are healthy, their bone density and everything goes back up?
Yeah, excuse me. We do expect those things to all heal. Now, like I said, we don't normally biopsy children to confirm that there's healing in the intestines, but there's been good data to suggest that in kids who are on a gluten-free diet, the healing rates of the intestines is over 95%. Now, for adults, it's more like 60%, but I think the reasons are probably because of adherence to the diet. In kids, we're just much more careful as opposed to taking care of ourselves, where we can tend to be a little bit more lax. It can take up to 2 years for biopsies for the intestines to heal completely. Okay, and it can take up to 2 years for the antibodies to go away completely, but oftentimes these antibodies will go away much quicker than that, maybe within 6 to 12 months.
Great. You have anybody over there, Tricia?
I have two questions. Has there been any correlation of how we have changed our farming and raising of our grains to celiac disease? Because like I have farming land, and we have changed our genetic re-engineering of our seed and those types of things over the last 2 decades. So I was wondering what studies were being done in that area.
I'll start, but that has been raised as a potential reason why we might be seeing an increase in celiac disease. I am not aware of any empirical evidence or studies that have supported it, but I thought I'd let Ed talk about it.
Yeah, I agree. I mean, we don't have a whole lot of information on that right now. There's some evidence that's growing now about people with gluten sensitivity that's non-celiac, where it actually may not be the gluten at all that's causing their problems, maybe something else in the wheat. But my best understanding of this is that the ancient grains have protein compositions that just, when you study them, they don't fit the immunologic profile that would trigger celiac disease, as opposed to like kind of our more modern grains. And so that may have something to do with it, but right now I don't have any other good evidence.
Right. The second part of my question is related. Is there any work or studies been done to look at celiac disease, because we're in this epidemic range, that the children that are coming in faster, 3 and 5 and stuff, came through diets where they were using commercialized baby foods, pre-made frozen foods, the lack of cooking from scratch, so to speak, the way I look at it. And if there's any work or correlation been done in that area.
Well, there's not specifically in the examples that you use, but in DAISY, we did look at that with regard to timing of introduction of gluten in the infant diet. And we did see an association between the timing of first exposure to gluten and risk of celiac disease autoimmunity in our DAISY kids. And it actually followed a very similar pattern that we were seeing for type 1 diabetes risk. In other words, an early exposure to gluten as well as a later exposure. So first exposure after the recommended time window both increase the risk for celiac disease. And so you might actually be seeing the result of a couple of different trends happening. Some trends of earlier exposure, and then in some cases some trends to delay the exposure almost on purpose to prevent things like allergies and celiac disease. We haven't looked at changes in the commercial baby foods or anything like that, but those are very good ideas. I'm not sure that we would actually be more able to look at that in TEDdy, given the way we've collected the data, to see whether we see some trends there. But that's a very neat idea, because I do think that in some cases where you see these changes in risk in a population, it gives you hints as to where to look for changes in behaviors or exposures.
Thank you for those 3-day diets.
Quick comment. So there's a host of substances that we are not measuring yet in TEDdy or DAISY. Those are antibiotics and chemicals made by bacteria, fungi, stuff that grows on food and or is added during the processing to preserve, or just random stuff coming from packages, from the machinery that we use to process foods. So this is an Achilles heel of our studies. Simply speaking, we are not collecting food samples because we would run out of space very quickly. and those agents go in tens of thousands or hundreds of thousands of different chemicals, small molecules. So there is no way to measure it within our budget at this time. But if you have any particular observations where you know about somebody who has developed diabetes and this person or family was on a weird kind of diet or some supplements that very few people use, share this information with us. It may not be included in our standard forms, but just talk to Tricia or Kim or others that you see during the TEDdy or DAISY visits, and we will be happy to make the note and try to follow up on those leads.
My question was partly for Dr. Liu. If you have a child, I don't know if you've looked at this at all or if you have any ideas about it. If you have a child who has the islet autoimmunity and then they also have a transglutaminase positive, are they at any increased risk for progression to diabetes, or do you think there's do you think the celiac influences the onset of diabetes at all?
I'm not sure there's actually any data right now. We don't have any data to suggest that having celiac disease is going to accelerate your transition from having antibodies to actual diabetes. Just like there's no data to say that a gluten-free diet is going to delay this or affect this in any way. We do see the overlap for sure. And right now for TEDdy, we're just actually not seeing as much overlap as we were expecting to see, and so we're still learning about that. You might have some other comments on this.
It was a very neat hypothesis forwarded by somebody from Italy maybe 15 years ago, that celiac disease causes inflammation in the gut, gut gets more permeable to not only nutrients but other stuff like byproducts of bacteria, and this may be the reason for inflammation in the pancreas and diabetes. Now, there was a clinical trial conducted by our colleagues in Germany called Baby Diet. It was published in Diabetes Care several years ago. They pretty much put randomly on a gluten-free diet for 9 or 12 months, high-risk relatives, offspring, children or siblings of people with diabetes. And they found no effect on development of autoantibodies to the pancreatic insulin-producing cells. So strict gluten-free diet did not protect those kids from developing autoimmunity and probably also diabetes, although they have not published the diabetes part of the study yet. So, and it's pretty consistent with what we've seen in smaller studies, and like in people who have early diabetes, they were put on gluten-free diet with the expectation that they will be losing their own insulin slower. It didn't happen. Markers of inflammation did not improve. So I think, as Dr. Liu is saying, those are two very distinct diseases caused by different factors. They just happen to share a lot of genetic susceptibility.
Dr. Norris, you mentioned that nitrates in cow's milk are also candidates, I think, to look at for additional risk factors. And I was wondering if you could share the data that led to that, or if there's additional studies going on with those.
Well, for the data on cow's milk, it basically started with the observation with breastfeeding. There was a temporal study done a long time ago in Sweden that showed that the decline in breastfeeding rates in post-war Europe was matched by the increased rates in type 1 diabetes that you saw in these countries. It generated a number of hypotheses that maybe breastfeeding was protective. But then that was extended to the idea, well, if you're not breastfed, then maybe you're being exposed to cow's milk, because if you don't get breast milk, you get a cow's milk-based formula. And so there's been a lot of research on the aged introduction of cow's milk formulas as a risk factor for type 1 diabetes. And I have to say that it's very contradictory. And in fact, in DAISY, we have never seen an association with timing of introduction of cow's milk and risk of autoantibodies and diabetes. However, there is actually an ongoing clinical trial that's multi-center, international, that is testing the hypothesis of where kids are randomized to a fully hydrolyzed formula or cow's milk-based formula when breastfeeding stops, and they're trying to see whether that makes a difference. So while DAISY, as well as other prospective studies like DAISY, haven't seen the association between cow's milk and risk of diabetes, I guess the question is still out. So that's where that stands. The nitrates and nitrosamines is an interesting. Actually, I could mention where it started. It's a smoked mutton story, but it. In Iceland, it was an observation. It's amazing. This is why we love getting these questions, and it helps epidemiologists to scan the newspaper for observations, because there was an observation in Iceland that there was a higher rate or risk of type 1 diabetes in kids who were born essentially in the fall, essentially 9 months after the holiday season, if you will. And the investigators had come up with this hypothesis that what was happening during conception, or at the time of conception in Iceland, what was different? Well, they noticed that, during the holidays, they ate a heck of a lot of smoked mutton. And so they came up with the hypothesis that the exposure to the nitrosamines
nitrates and nitrosamines that you get in a smoked product like smoked mutton might have increased the risk of diabetes in the kids who were being conceived at that time. Now that is a single observation that really can't be replicated anywhere else in the world because nobody else eats smoked mutton. But however, there have been studies since then that have done some sort of ecologic studies where they've correlated nitrates in the water in geographic regions with increased nitrates in the water with increased risk of type 1 diabetes. Now, there's a lot of problems with these sort of ecologic studies because there's a lot of differences between these regions who have high nitrates, but it certainly generates hypotheses about preservatives and chemicals that I think Dr. Revers had mentioned, things that are actually quite difficult to measure in day-to-day life and diet, but are things to consider when we have a really focused hypothesis and the samples to measure. So there have been a number of studies that have been in agreement with this sort of generalized, oh, wow, you see higher rates of diabetes where there's greater nitrate exposure, but it's not nearly to the level that we've been seeing in some of these prospective studies like DAISY and TEDDY, where we've really been able to nail down exact exposure to the child. So I guess I have to say the question is out because it's actually quite difficult to measure nitrate exposure in kids, and so we have to resort to these sort of geographic correlations. But once we come up with maybe a good biomarker, like a urine sample or a blood sample, we can actually test it. It's a very interesting hypothesis to consider.
Is this part of the reason that we collect water?
Exactly. We are trying to drive this point home. Water sample and urine samples. If you have not, for those of you who participate in TEDDY, if you have not brought your tap water sample to the clinic yet, please do it at your next opportunity. And urine samples are very important. We added urine samples late to TEDDY because we didn't want to overburden you and your kids with too many demands. But we wanted to do it from the get-go. Urine is relatively easy to obtain, as you know, and it contains a lot of distilled, you may say digested products like proteins and also minerals and small molecules that the body wants to get rid of. So we are freezing those urine samples, and we'll come back to those samples, probably not next year or in the next 2 years, but those may turn out to be a gold mine, if you will, for the study and for diabetes research.
Thank you for providing all this information for us. I have two questions as well. I noticed in one of the slides it said that it showed 3 to 4 years for the onset of celiac. Is that about the age that you're seeing for the TEDDY study?
So the age of onset, I mean, right now our data is only up to 5 years on average. So that's why we're looking at really the early onset. I mean, just like in DAISY, we saw the incidence by 5 years was about 1.5%. But as these kids get older, more and more of them are going to continue to get antibodies. And so that's the same thing with TEDDY. So the youngest child that's developed celiac disease came from Sweden and was 9 months old. And, so we're just seeing the beginning of this right now.
And along the same lines as something that you had mentioned, I know that we are requested to write down any sicknesses or medications. Are you seeing any correlations with celiac or diabetes for that as well?
So I think I can tell you a secret that nobody in the world knows yet because we haven't published it yet, but we were especially interested in medications that are given often to a lot of kids, like those given during febrile infections, Tylenol or ibuprofen, Advil. And there are very interesting observations. I think what we are seeing is going the opposite way to what we would expect. That some of those drugs that we thought would, and I'm not going to tell you which direction it goes because you would stop or start giving those drugs at will, right? But there is something about fever and how we treat fever that may be related to the risk of autoimmunity and diabetes. There is a huge interest in looking at antibiotics because we probably overtreat our kids for a lot of infections. They don't need an antibiotic, but you take your young child to a pediatrician like myself, and we look in the ear and say, oh yeah, it looks red. Well, just in case, to cover our insurance risk, we'll prescribe amoxicillin or something of that sort. And of course, there's a lot of antibiotics in meat, chicken, beef, in drinking water, because it all goes down to the drain, and eventually we probably drink it today as well. So there's just too much antibiotics, and we can measure some of those exposures. At least what's prescribed and what you give to your kids when they get sick, in TEDdy especially. And we expect to see a relationship. I don't know which direction it's going to go. Is it going to be protective? Maybe some antibiotics are protective and some are not. But this is something that we are analyzing as we are having this meeting. So stay tuned. But if the kid has fever, follow what your pediatrician is saying.
Dr. Rivers, last year when you presented, you had stated that when you see 2 or more positive antibodies, that those kids would develop diabetes. The question wasn't if, but when. Is that accurate?
It is accurate for at least 70% of the kids. So we published the paper in one of the very visible journals of JAMA, Journal of the American Medical Association, last June. It simply shows that regardless of the country the kid was born in, regardless if this child has or does not have anybody with type 1 diabetes among his or her relatives, if there are 2 antibodies on at least 2 occasions, 70% of those kids will develop type 1 diabetes in the next 10 years. So 10 years is a long time in the life of a child. And, some kids really develop it very rapidly. Some take 10 years or even longer to develop diabetes. We'd like now to take the next step in this work and find out what determines the time or the rate of development of diabetes. And then there are those 30% of kids who stubbornly refuse to develop diabetes. And I think there is a golden nugget there that we have to figure out. What makes those kids resistant to diabetes? They seem to have the same genes as those who go quickly to diabetes, and the same family histories. So there is something that makes a difference. And it may be something that you guys do inadvertently at home. And we are, I hope, measuring in those questionnaires that you are completing. So this is the next frontier. We really want to figure out the outliers, those kids who are resistant and those kids who are slowly progressing to diabetes, because prevention may be in those observations.
My question is about how type 1 is related to celiac disease genetically. So obviously they're both autoimmune, but how are they connected genetically? Do you inherit the same type of genetic profile for one that you would for the other, and then just one gets turned on but not the other?
So, the genetics of celiac disease are pretty straightforward when it comes to the major risk. It's having sorry, I keep switching between DR and DQ, but having like the DR3 DQ2 gene is your big risk for getting celiac disease. And the other gene that puts you at risk is the DR4 DQ8 gene. Now, those are also the same major risk genes for type 1 diabetes, but there's also a lot of other smaller HLA type genes that put you at risk. But the reason why celiac disease and diabetes mostly go together is because of those two genes. Now, remember, you inherit one gene from your mother, basically you inherit one from mom and one from dad, and depending on the combination, so if you have two DR3, DQ2 genes, you inherit the two big ones from each parent. For celiac disease, your risk of celiac disease is much higher, but that same gene combination where you're DR3, DQ2, DR3, DQ2, where you have two copies of that, is actually a relatively lower risk for diabetes. So the genes put you at risk for both conditions, but depending on the combinations that you inherit from both parents, plays a big role in whether or not you're more likely to develop diabetes or celiac disease. Now, those are the big genes, but there's, for celiac disease, there's, dozens of other minor genes, and same with diabetes, minor genes, that also are associated with increased risk or decreased risk for diabetes or celiac disease. And between diabetes and celiac disease, there's probably maybe a dozen or so genes that are actually shared between the two that are associated together. And so having those additional genes may also kind of, maybe it may make you more predisposed to getting both together. But the effects of those genes are so minor right now that we can't use those other genes to try to predict disease one way or the other right now. So the major ones we use are still like the HLA genes, which are used to screen your eligibility for Daisy and Teddy. Does that make sense to you?
Oh, you got him on that side, Tricia.
On those kids, you're saying that 70% of the kids with those genes are going to eventually get diabetes, or that's what the study shows. Have you seen any correlation in that 70% with the weight or obesity of the kids?
Okay, so I will answer the first part of your question, and then Dr. Norris will answer the rest. It's not genes, it's antibodies. Okay? So those genes are great, as Dr. Liu said, for finding people who are at higher risk, but then most of those people, 90% of those people, never get any antibodies or disease. So what I was saying, you have to have two antibodies, two types of bullets that the white blood cells are shooting at insulin cells in the pancreas, and it's proved that there's a fairly strong inflammation in the pancreas. If you have that, then the risk is 70%. Now, I will refer your question concerning the effect of weight or obesity on development of those antibodies or diabetes to Dr. Norris.
So there has been some research. There was a hypothesis proposed. It's called the accelerator hypothesis, but it's basically based on trying to link the increasing incidence of type 1 diabetes to the increasing trend of obesity in young kids. And so the hypothesis suggests that the increasing obesity is accelerating the process and having kids develop type 1 diabetes at a greater rate. And there have been some studies that have supported this. I do have to say that we did look at this in DAISY, where we measure, as you know, in the clinic visits, we measure height and weight. And we actually do not see that an increased weight is associated with risk of autoimmunity or risk of progression to diabetes. In fact, we saw an opposite effect, that it's a slightly decreased weight is associated with increased risk of autoimmunity, but it's very small, so I don't really want to interpret it. But basically, that hypothesis is not borne out in the DAISY populations. We don't see the kids who are heavier converting to diabetes or autoimmunity more frequently.
We recognize it is 8:15, and if people are starting to filter out, that's why. But we'd love to keep entertaining questions. So there was some right here. Did you have?
So I heard last Friday on Science Friday on NPR that there's a professor from the University of Wisconsin being interviewed about evolutionary changes, and the question was posed, how are we evolving? Celiac disease was one of the examples that professor gave as being our inability to tolerate wheat is something that is relatively something that is, or our ability to tolerate wheat is something new, evolutionarily new. And I just was curious, fact or fiction?
Yeah, I think that's true. We're not evolving fast enough to tolerate the wheat that's sort of more modern, right? The ancient grains, have protein structures that when you look at at our immune system, we should be able to tolerate. And these ancient grains wouldn't have caused celiac disease, but because these grains have become more modern and they were cultivated based on, so many other features, right, in terms of resistance and growth and all those things that, I think humans just haven't been able to evolve fast enough to accommodate for this. So I think it's a good theory, and I believe it.
So I'm a little confused about the whole old standard, if you will, or for celiac being just in the gut, and now it's more than the gut. So my children are late teens. Were diagnosed. One was diagnosed at age 5. He's still not gluten-free, much to his mother's dismay. But they feel they're asymptomatic. I was diagnosed because of him. I feel I'm asymptomatic most of the time, but I know I'm gluten-free, and I'm afraid to go to gluten because of what that might mean. If we're not having gut issues, they eat something and they feel crappy. That doesn't seem to happen for them. What about the gold standard being the biopsy? Does that biopsy mean, I don't know what the question is. Does that mean the asymptomatic symptoms are I'm sorry, I don't know how to word this. So if we do a biopsy and they say, yes, you have celiac, then we know they have celiac. We don't do a biopsy, but they have asymptomatic things going on. How do we know what those are? Is the biopsy?
Those are great questions. I mean, there's a lot of unknowns with this, right? And so, having celiac disease and having intestinal injury doesn't always correlate with the amount of symptoms you have.
Okay.
So, sometimes it's useful to think of it like hypertension. So, you might be asymptomatic, but you have high blood pressure, and it's not going to affect you until much later on down the road, right? And the same thing can hold true for celiac disease. But now, if you've never had a biopsy, but you've had antibodies, then that remains a gray area. We don't know if you have celiac disease, or what's happening with these antibodies. Do you have celiac disease or not? Oftentimes, if the antibodies are still present and if they're very high, then your suspicion that this is really celiac disease goes up even without a biopsy. And there's actually some suggestion in the European community to make criteria to diagnose celiac disease without a biopsy. It's something that the North Americans haven't really adopted yet. We're not so fond of that for a lot of reasons. And the main reason is because there's still uncertainty, sort of like this, right? Especially in kids who don't have symptoms. So
maybe we have symptoms and we don't know it.
Correct. Because there's also kids who may have symptoms and don't recognize it, but when they go on the gluten-free diet, they realize that they feel better, or that they don't think they feel any better, but then suddenly when they start eating wheat again, they recognize that they actually feel sick. They become more sensitized to it.
So is there a severity of celiac? If some of their doctors have said, oh, if you don't have symptoms, what are you worried about? Well, the mother's worried about it, the kids aren't. So what does that mean?
That's a great question too. So the same thing. The part of the overt symptoms are pretty obvious, and that's enough motivation for anyone to go on a gluten-free diet. If you're feeling sick and you're vomiting and having diarrhea, it's hard to motivate a teenager when you tell them that, well, your symptom may be that you get iron deficiency or that your bones are getting thinner. And it's very, very difficult to motivate teenagers. It's something where we keep working on them and just keep on discussing it. Then eventually, as we show more evidence, eventually, we hope that they'll come around.
What do you say to the doctors?
Well, I don't really agree with that. So, having no symptoms, that's just the tip of the iceberg, right? I mean, the tip of the iceberg are the kids who have the overt symptoms, but the majority of people with celiac disease actually don't have many symptoms at all, and so they're unrecognized. And, one symptom may be vomiting, but the other symptom may be, osteoporosis or iron deficiency, which you can't tell just by looking at someone and asking them. So these are very subtle symptoms, right?
So we were diagnosed because of this study, and many people wouldn't necessarily be part of the study, but are you saying then that perhaps the gut is not the first of the symptoms for celiac? The biopsy is sort of an old-fashioned way of diagnosing celiac disease, but it's still the best way because, and maybe this is going to change in the future when the antibody tests become better, when we start to understand the antibody tests better, so that we do feel more comfortable, maybe in the future, of diagnosing celiac disease without a biopsy. And certainly I've diagnosed kids without a biopsy just because we work together with the families, and we don't want to be strict by the book when we're dealing with real life situations. But was that because of the gastrointestinal type of things?
No, it may not even be because of that. We kind of look at the whole picture. So just because you don't have a biopsy, it leads to uncertainty, but it doesn't mean that, we can't treat you as if you've got celiac disease if we're worried about long-term complications. Now, to be fair, if you're asymptomatic, there are adults, when they're followed for a long time or who've probably had celiac disease for many, many years, who have minimal symptoms or minimal complications. And you might wonder, well, is it worth it to go on a gluten-free diet for 40 years to save my bone density just by a little bit, or to treat a little bit of, iron deficiency anemia when I'm otherwise healthy? So we don't know in kids, though, who's going to develop major problems in the future versus who's going to develop minimal complications. And so, dealing with asymptomatic kids is always a bit of a dilemma, but I think it's a bit of an easier decision in kids because we just don't want to take that chance for kids. Their job is to grow and develop. And so, my bias has always been that if they've got evidence of celiac disease, we do want to treat them, and the question is when. And, obviously, some teenagers just aren't ready yet to be treated, but, bring them in and we talk and we just keep working on it with them, and hopefully they'll come around.
Thank you for that.
Well, questions. You've brought up ancient grains a couple of times. On the web, it's all about sorghum and millet and amaranth and quinoa and that kind of stuff. Is that what you're talking about, or are you talking about previous versions of wheat?
Previous versions of wheat. Yeah, the millet and the sorghum, all those things are good alternatives. Those are good, non-gluten alternatives, and good sources of fiber, too. Okay.
So you had mentioned, I think last year, Dr. Evers, you had mentioned that height was more of a determinant than weight was. Is that still coming the case? And to tie into that, from what I've heard today, I've heard that omega-3s, if they're not showing autoimmune, any of the antibodies yet, are a good thing to do for our kids. Chopping his knees off is a good thing to do. Well, keeping his height down. Are there, in the studies, are there any other things that can be pointed to specifically that I can do for my son who is currently not showing any of the antibodies yet, but his brother's got diabetes, his grandfather does, his father does?
How old is
he? He's 6.
I was just going to touch on the observation, or you're recalling what Dr. Evers said last year. When we were looking at weight in DAISY, we also looked at height and BMI because we were interested in obesity in our kids.
And while these things didn't seem to play out with regard to that obesity hypothesis or the accelerator hypothesis, one thing that we did observe was it wasn't necessarily the height of the child, but how quickly the child was growing, what we call velocity of growth in height. So that was an observation that we saw in our kids, and it increased the higher velocity, increased growth, seemed to increase the risk of autoimmunity and increase the progression to diabetes in the DAISY kids. But as you said, what do you do with that information? You're not going to try to keep them from growing, because usually,
If you don't catch them.
But I think this gives us clues as to what might be going on. Again, maybe related to the stressing of the pancreas. I mean, a rapid growth could actually be a stress on the body in general and make it vulnerable to autoimmune attack in some generalized way. So it's a clue to research further, but it's certainly not something that we would intervene on. In terms of, basically, what my presentation tried to highlight were those types of factors that I think had a number of different observations from different studies that were suggestive, but they weren't necessarily absolute. There are non-dietary factors that people are also researching, and I'm not necessarily prepared to speak about those. But I think that one of the things that we want to be careful is that people don't try to do things that are unhealthy for their child, because there are unintended consequences to things that maybe even seem benign and healthy. There can be maybe too much of a good thing. And honestly, it's a valid concern, and every parent wants to do something. And I think what you need to do is weigh the information that you grab here, talk to the pediatrician or the physician that is treating your child or observing now that they're healthy, and make some decisions about what would be healthy changes, perhaps like exercise or things that maybe have benefits throughout. Most of the things that we're researching aren't necessarily targeted just at diabetes. They have overall healthy implications. So in other words, I think that in general, these are really good things to consider, because there could be good consequences all around. But we don't necessarily have a single thing that we can say, this is what's going to do it. And honestly, I think the best thing to do is weigh all the different options and talk to the pediatrician.
I think it's a great summary of our thinking in terms of what message we are sending to you guys. You as the parents, you know best. With your family members and physicians, you have to make sometimes tough decisions. Unless it's proven in more than one clinical trial, I would not take the extra risk of doing something really unusual with your precious children. And it leads us to closure. I would like to thank Judy and Tricia and Michelle and Rachel and Kim and Iman and Megan and Haley and probably a few other younger additions to our staff that I missed for organizing this event. I would like to thank very much for your time and the great questions that you shared with us today. And I would like to thank our excellent speakers tonight. Come back next year. We'll have more exciting stuff for you.